I'm about to tell you something that will make a lot of doctors uncomfortable. This sentence, amputation is your only option. It is one of the most dangerous things a patient can hear in medicine. After 25 years, I've decided I will no longer accept it without a fight. The most complex cases in my field, that's where I live. Patients who come to me as a last resort, managing diabetes, severe infection, complete tissue loss, compromised blood flow. 25 years of those cases, that's where this conviction was forged. In this video, I'm going to take you through exactly where this conviction comes from, what forged it across 25 years of practice, and what it means for any patient sitting in a room right now to hear the words, "There's nothing left we can do." Because almost always something's left, and you deserve to know what that is before you agree to anything. For a long time, the default assumption inside medicine has been that certain cases are simply beyond recovery. That when tissue is damaged enough, when infection has spread enough, when blood flow is compromised enough, amputation becomes inevitable. This assumption gets passed from specialist to specialist, from training program to training program, until it becomes muscle memory. A patient shows up with a severe diabetic foot wound, and a sudden cascade of consultations all land on the same conclusion. Why? Because they were all trained by the same framework. It's spread because it's faster. One consult, one recommendation, a patient who's scared, exhausted, and willing to agree to almost anything to stop the suffering. And because most of the specialists making that recommendation, they're not limb salvage specialists. They're doing their best within the limits of what they were trained to do. An infectious disease doctor isn't a reconstructive surgeon. An orthopedic surgeon isn't a wound care specialist with 25 years of complex foot and ankle cases under their belt. They're not wrong for the limits of their training, but those limits shouldn't be the ceiling for the patient. The flaw is that the recommendation travels as if it's final. When an ER physician says amputation, the patient hears every option has been considered and ruled out, and that's almost never actually happened. What happened is that every option within the specialist scope was considered, and that scope is not the whole map. When I hear that someone has been told no other options, and I look at the case and I see blood flow that can be restored, or a reconstructive approach that was never attempted, or an infection that can be treated with something other than removal, my reaction isn't clinical detachment. I feel it in my chest because that patient was told something that wasn't true, not out of malice, out of limitation, and that they were about to live with the consequences of that limitation the rest of their life. Look, this isn't about blaming doctors who made those recommendations. Most of them were working on the outer edge of what they knew how to do. This is about a system that doesn't reliably get patients to specialists who can see the full picture before the decision is made. And that's the gap I've made it my mission to close, one patient at a time, for 25 years. The position I now hold publicly and without qualification is this: no amputation recommendation should be accepted as final without a limb salvage specialist's opinion. Not because every limb can be saved, some can't, but because in the majority of cases I've seen in this field, a path existed that was never explored. And every patient deserves to know that path existed for them before they consent to losing a part of their body permanently. A patient named Alice came to me at 43 years old with Charcot foot, a condition severe enough that she'd been told to accept significant permanent limitation. She's been counseled to give up on the idea of normal footwear and normal activity. We performed staged reconstruction. She returned to regular shoes. That outcome was possible. It had never simply been attempted. Her case is one of hundreds I could name, and every one of them is the reason that this conviction exists. When you operate from this conviction as a patient, the first thing that changes is your relationship with the word final. No recommendation is final until a specialist in limb salvage has reviewed the case. That one shift in how you receive information can be the difference between keeping your leg and losing it. And what I want to get into next is the pattern I've seen across 25 years that explains why this specific gap exists and what most doctors never actually learn about it. There's a belief inside medical training that's rarely spoken aloud, but shapes almost every clinical decision. Your ability as a doctor is defined on what you learned in your residency, the tools you were given in those years, and the tools you use for the rest of your career. And in a case exceeding those tools, the answer is to refer out, manage expectations, or recommend the most conservative intervention available. It spreads because it's a reasonable belief up to a point. Residency is intensive. Your training is rigorous. Most physicians finish genuinely capable of handling the cases within their scope. The problem is medicine advances. New techniques for restoring blood flow, new approaches to infection that preserve bone, skin flaps, muscle flaps, artificial skin substitute that change what tissue loss actually means for patient outcome. The baseline of what's possible shifts. The flaw is that patients can't see any of this. When a board-certified specialist tells them there's nothing left to try, they have no way of knowing whether that assessment reflects the current state of medicine or the state of medicine from a decade ago. They take the recommendation at face value because they have no framework for questioning it. And the recommendation is made with complete confidence because the doctor genuinely believes it to be true with the limits of what they know. I've treated patients with every level of tissue loss. I've seen cases where the wound was so severe that every reasonable observer would have said the limb was beyond saving. And I've seen those limbs saved because there's no level of tissue loss beyond the reach of reconstruction. If the blood can be addressed and the infection can be managed and the right surgical technique is applied, the gap between what's possible and what most practitioners believe is possible, enormous. And those patients are living inside that gap every single day. I'm not suggesting that every doctor needs to know how to perform complex limb salvage reconstruction. That's unrealistic and unnecessary. I'm saying that every doctor needs to know when to say, this case is beyond the scope of what I can offer, and the patient needs a second opinion from a specialist before we proceed. That's not a failure of competence. That's exactly what good medicine looks like. I've learned in 25 years, and what I try to pass on in every conversation that I have with colleagues and patients alike, is that a commitment to continuing education isn't optional in this field. The doctors who continue to expand what they can offer patients, those are the ones who should be the last word on whether limbs can or cannot be saved. Not the generalist, the specialist who trained 20 years ago and hasn't revisited the evidence since. The limb salvage specialist who actively works at the edge of what current medicine can do. There are advanced treatments available today for restoring blood flow that weren't in widespread use 10 or 15 years ago. There are infection management protocols that preserve bone in cases that would have previously required removal. There are reconstructive options available for every level of tissue loss. These aren't experimental, they're established. They're what a limb salvage specialist trained in current technique brings to every case. And they're what's missing when a recommendation of amputation is made without that specialist in the room. When doctors commit to learning past the boundaries of their original training, the ceiling for their patients rises with them. That commitment is something I consider non-negotiable in my own practice, and it's the standard I hold every recommendation to, including my own. Now I want to talk to you specifically and how to know whether what I'm describing applies to your situation. If this is the kind of content you want to see more of, subscribe now. I publish videos like this regularly because I believe every patient deserves to make decisions from a place of information, not fear. You may be watching this because you or someone you care about recently heard the word amputation may be necessary. Or you maybe have been watching because you've been living with a foot or ankle condition for long enough that you've already started to wonder whether the options you've been given are actually the full picture. Either way, there's a specific kind of exhaustion that comes with being a patient in a complex medical situation. You've seen multiple doctors, you've heard multiple opinions, and somewhere underneath all of it, you have a question you may not have said out loud yet. Is this actually as far as medicine can go for me? The patient who comes to me with the most complex cases often share a common history. They were seen by a primary care physician who referred them to a podiatrist. The podiatrist managed the case for a while and then referred to an orthopedic surgeon or an infectious disease specialist. When the situation escalated, each of those specialists gave their honest assessment within their scope. And by the time this patient hears amputation, they've already been through enough that that word lands with a kind of finality that's very difficult to push back against. But here's the question that should be asked, and almost never are. Has a limb salvage specialist reviewed your case? Has the blood flow to the area been evaluated with current vascular testing? Has reconstruction been assessed as a potential pathway? Has every level of wound care and infection management available today been considered? If the answer to any of those questions is no, then the recommendation of amputation isn't a final answer. It's an answer that came within a limited framework. What it means for you is that you're not required to accept a recommendation as final simply because it was made by a credentialed specialist. You're entitled to a second opinion. You're entitled to have a limb salvage specialist review your case. And if access to that specialist is an obstacle, I want you to know that I can take a phone call from patients across this country and international. I give every patient a personal cell phone. If someone tells you that you need an amputation and you want another opinion, you can call me directly, regardless of where you are. That's not a marketing line. It's what I've been doing for 25 years because I believe access to the right doctor is the single most important factor in whether a patient gets the outcome they deserve. And what I want to close with is this specific shift that happens for a patient when they take this conviction and put it into practice, because it changes the entire shape of conversation with their medical team. There's a difference between a patient who receives a recommendation and a patient who engages with a recommendation. Most patients, by the time they're facing serious amputation discussions, they've been in the system long enough that they've learned to receive. They come in, they listen, they nod, they leave. The system moves quickly and rewards compliance. And most patients, even with something inside of them saying, "I'm not sure about this," they don't have the language or the framework to articulate that uncertainty in a way that changes what happens next. The shift I'm talking about is giving that uncertainty a direction, not panic, not confrontation, a specific informed question. Has a limb salvage specialist reviewed my case? That question asked in the right moment changes the entire dynamic. It signals that the patient isn't simply accepting the frame they'd been handed. It opens space for a different kind of conversation. I've seen patients arrive in my office in cases where the conversation with their previous care team had already moved past the question of whether to amputate and into the logistics of when. And after a complete evaluation, after looking at blood flow, after reconstructive options, at the current state of the wound and what current techniques could offer, the answer was, there is a path that hasn't been tried. That shift from when back to whether is what a second opinion from the right specialist can deliver. Stop accepting the word only in a medical sentence without asking who else has been consulted. Amputation is your only option. It's a sentence that requires a limb salvage specialist to be in the room, to review the full workup, and having assessed every available avenue before it's allowed to stand. If that hasn't happened, the word only hasn't been earned. Start treating second opinions as a standard step in any major medical decision, not a sign of distrust. You wouldn't accept a single bid for a significant home renovation. You wouldn't make any financial decision based on one person's assessment. A recommendation that involves a permanent removal of your body part deserves at minimum the same standard of due diligence. And that brings me to one concrete step I want you to leave this video with tonight. Most patients who hear an amputation recommendation aren't going to act on it tonight. The appointment ends, they go home. The weight of the recommendation settles in, that window, the hours and the days immediately after. It's when the question of second opinion is most likely to be pursued or quietly dropped. The patient who gets a different outcome are the ones who act within that window. Think of it as a difference between leaving a fork in the road and committing to one direction. Once the decision is made and the date is set, returning to the fork becomes exponentially harder. The window before the decision is where a second opinion has the most power to change the outcome. A second opinion from a limb salvage specialist doesn't delay your care in any meaningful way. What it does is ensure the path you choose is the right path, and you choose it with full information. If the answer after the second opinion is still amputation, you'll know that recommendation came from a specialist best positioned to make it. And if the answer is totally different, you'll have a leg. Tonight, if you or someone you care about receives an amputation recommendation, write down one question. Has a limb salvage specialist reviewed this case? That's the question. Take it to your next appointment. Ask it aloud. If the answer is no, request that a review before any decision is made. If you don't know how to find a specialist or you want a direct second opinion, my number is on my website. Call it. That's what it's there for. 25 years of practice has taught me one thing above everything else. The patient who gets the best outcome aren't always the sickest or the healthiest. They're the ones who ask the next question. Every part of the foot, ankle, and leg is worth the effort of trying to save. That's not optimism. That's what I've seen with my own hands for over 2 decades. If you want to go deeper on the questions patients face in these situations, the ones that most people are afraid to ask out loud, watch this video. It's called What Diabetic Patients Are Too Afraid to Ask Before Agreeing to Amputation. And it covers exactly what should happen in that room before you sign anything.